looks like everybody is about in. So thank you all for joining us this afternoon. We're so thrilled that you took the time to learn with us today. My name is Rebecca Jones, and I'll be moderating today's ARCS Forward event. So today's event will be recorded and available on ARCS Foundation's website and our YouTube channel. We will have time for questions at the end of the presentation. So please put your questions in the Q&A box located at the bottom of your screen. If you put them in the chat box, we may miss them. We will hear from an accomplished ARCS Scholar alumnus, Dr. Eric DeJesus. Dr. DeJesus is a scientist, entrepreneur, and founder and CEO of Annate Bitherapeutics. His work centers on harnessing a unique component of the innate immune system to selectively kill cancer cells, with lead programs targeting multiple myeloma and pancreatic cancers. Beyond the science, Dr. DeJesus is deeply committed to developing transformative therapies, not just for cancer, but for human diseases more broadly. His team has built strong preclinical proof of concept data, secured intellectual property, and is driving the path toward clinical development. Thank you for joining us, Dr. DeJesus. We're excited to learn more about your ARC story and your fascinating research.
Thank you so much. I really do appreciate the time to come here and speak at ARCS Forward. And I know that my Atlanta chapter is out there, and I've seen several show up, and I do appreciate you all for everything. So happy to be able to share today on how we started, going back all the way to the very first day of having that pivotal question. So don't worry, we're gonna touch up on how ARCS Atlanta wraps into this story. Am I good to share now? Good to go?
Yes, you're good to start.
All right.
Thank you.
I appreciate it. You all let me know if that comes through. I think you should be able to see this. All right. So we started this back in 2009 when I started my PhD at the University of Georgia. And the title today is really how in the world that a small African parasite called an African trypanosome can actually potentially change the way that we're looking at cancer treatments. So again, I really do appreciate y'all being here today. So let's dive right in on African trypanosomes. First question I had, and obviously what you might have, is what in the world is a trypanosome? So if you go back to your biology book, that's probably 600 plus pages. These small parasites are probably maybe 2 paragraphs. So it's okay if you don't quite remember what those are. And that's the very question that I had back in 2009 and 2010. And simply put, these are small little protozoan parasites that can infect our blood. This is actually them imaged right here amongst some red blood cells under microscopy. And the 2 briefly that we will go through today are Trypanosoma brucei and Trypanosoma brucei gambiense. The brucei is able to infect cattle, and in sub-Saharan Africa, where these are found, will create a disease called Nagana. But if gambiense gets into us, it creates African sleeping sickness. And that's the primary thing that's the background of parasitology you need to know for today. So the unique thing about this, and when I met with Steve about talking through what potential things we could be studying, this is where he started to entice me about working on parasites, because he said, oh, brucei doesn't infect us because within 2 hours, there's something in human serum that kills them. Okay, that's interesting. What is that? And he goes on to tell me, oh, it's something that we've termed trypanosome lytic factor, which is just an HDL in us. I'm like, an HDL, like a high density lipoprotein that you go to the doctor's office once a year and you get your blood work with HDLs, LDLs. He's like, yes, it's one of those. He said that's actually a component within it termed apolipoprotein L1 or ApoL1. And that protein is very toxic to those parasites. They have a specific receptor for it. They take it up and it's really toxic. Sitting there thinking, okay, all right. And I said, okay, well, that's great. Well, what are we going to study? He said, well, gambiense doesn't take this up, Brucei does. I was like, wow, that's fascinating stuff. But my mind came from a cancer background. I came to grad school to study cancer, and I joined a lab, and that was going great up until the money fell through in late 2009, going into 2010. So I had to shift to find a new lab. And Dr. Steve Haydick, who was the PI of this lab working on these parasites, said, well, he was the head of the department. So I naturally had to go to him to find a new lab. And he said, well, why don't you study the differences here and try and figure out some of the things of what's going on with Gambiense compared to Brucei? Now, mind you, my mind was always cancer. And now I'm sitting in this office looking at trypanosomes. And I was like, well, I don't know how I get back to cancer if I go down this road. And he said, well, what interests you on biochemistry? And I said, we went through the things that I found interesting. And he said, well, look at this as just a model system, and then you can extrapolate your studies from there further down the road. And I said, that's okay. And when he really started going through this, all I saw was a drug. I saw a drug that kills one version and doesn't kill the other. And I asked a really simple question. I said, well, why doesn't this HDL particle hurt us? He sat there for a moment and he's like, well, I don't really know. I'd assume we just don't make enough of it, maybe. Um, I don't know if we have a receptor for it. Maybe we don't. No one's really ever looked. And I said, okay, well, can we make it harm us? Can I see if there's a way to make it harm us? He's like, I don't think I'm following you. I was like, can I target it and kill cancer? He's like, oh, geez, I don't know. I'm a parasitologist. I don't study cancer. Okay, but can I try? He's like, Eric, I'm a parasitologist. I don't even know how to really start those studies. And this is really what all our grants are focused on. And I was pretty persistent. He said, how about this? To defend your PhD at Georgia, you have to get some papers under your belt. You do that, and then I'll let you go off into the wild blue yonder and try and figure out this pipe dream. So that sounds pretty good. So that's what we did. And for those of you who are like, oh my goodness, we're going to talk about parasites all day. That's about it. We're done with the parasite talk because I published 2 papers in my first 2 years in his lab on the parasite side, and then we moved on. I absolutely have wonderful memories of that season of life, and the science is fascinating to me, and we still go back to that to try and understand what we're seeing today. Um, but then I got to be able to the opportunity to go back for my last year and a half and push on those questions. It's okay, how do we get there? How do we see if it's possible to kill any mammalian system with APOL1? And that's where these studies started. This is actually part of the data that went into my ARCS application. What we see here is just standard kidney cells, which we call HEP293s, and just physiological normal amounts of APOL1 in HDLs. Okay, happy cells. Great. And then we have a way to pull out that protein and leave the rest of the HDLs there. But I went really high on the concentration of the HDLs. So that's what we see here. And they're still happy. When you put high amounts of APOL1 back in, that's when you start to see, uh-oh, we potentially have something here. We clearly have something here, actually. But the challenge is it was almost 10 to 15-fold higher amounts of APOL1 than we actually make ourselves. So that's one defense mechanism. We just don't make enough naturally. And it turns out we don't have a receptor for it. So that's 2 levels of defense against this particle not harming us. And that's what we put into this application here. It was, we wrote up that little figure and said, hey, we're working in this direction. And we think we found a really strong intersection of research between parasitology coming out of sub-Saharan Africa and the beginnings of what has now become a cancer project with some real teeth. And we were very fortunate to be able to land the Hertz Global Impact Award, got to go to Atlanta and give a brief little snippet of what we were doing there. And I've had such a soft spot in my heart ever since for ARCS because they were the first to take that leap of faith on the baby step of research that has turned into now. And I'm very curious if there's any students across the country in ARCS, under the ARCS umbrella, that are still working on a project out of their lab and that they received funding from even recently up to years ago. I'm just very curious about that. So this was a fascinating project up until the very unfortunate reality of Steve's wife, Anne, being diagnosed and starting a battle with multiple myeloma. And obviously it doesn't take too much of a stretch of imagination to think that working on a potential cancer project and having your spouse battle multiple myeloma is not something you really want to try and juggle. So I did my defense. We pushed pause on everything. And if you see the timeline down there, we pushed pause for a while. So I did a postdoc and got a career at the USDA in town, kept in touch just enough to say, hey, I'm still here, and let them go through that very, very difficult time. And I thought about the project all the time. So in 2019, of summer 2019, we actually did lose Anne. And in January of 2020, right before the world shut down for a little while, we ran into each other. Steve and I ran into each other. I gave him a big hug and said, I'm so sorry to hear about Anne. Um, how are you doing? And he said, thank you so much. And the first thing out of his mouth was, hey, do you ever think about that project? I said, Steve, I've thought about it every single month since we stopped. And he's like, well, let's meet because we've got some developments that I think we can go after on using it towards multiple myeloma. And I think we have a way to deliver it. I was like, well, I'm fascinated to see that. But do we even have the hands to do it? Because it's been a number of years since we've done this work. And there was more work done. And we just had the concerns of if we can even get APOL1 to do anything in cancer. These were kidney cells, so maybe there's a difference in cancer. Well, it turns out there wasn't. They saw the same dose-dependent sensitivity the higher you push APOL1, well beyond physiological, which, if you can see my mouse, is right around 3 micrograms per mil. This is physiological. This is about how much we have in us. Everyone does. So to go up to 50, we're not going to just accidentally start making that much. It's just not going to happen. But the question was, that's great, but how do you deliver it? And how do you deliver it at this lower dose and see if you can do anything? So that's where we created Annate Bitherapeutics. And our background expertise is in the human innate immune system. And I knew as soon as I sat down to come up with a company name, I just wanted to honor Anne. So that's why I named it Annate. Sorry about biotherapeutics. You can just say innate. Biotherapeutics is a very much of a speed bump of syllables. Sorry about that. So, at Innate, we're harnessing the power of the human innate immune system for the treatment of multiple myeloma, and as you'll see, hopefully many other cancers. So, going back to first, what was a trypanosome? Well, now what is multiple myeloma? And if you haven't had any experience with it, it's really a cancer of the plasma cells. So it starts in the bone marrow where all of your antibodies start to come from, and it just shuts everything down and makes it dysfunctional from there on out. It's actually the second most prevalent blood cancer and represents about 1% of all of all cancers overall. And there are about 35 to 40,000 new incidents a year and about 50,000 people currently struggling with it in the US right now. And we're losing about 15, 18,000 of them each year. And since they've been really keeping decent records since '05, it's been about an 8% prevalence, mostly because of the rising population and better diagnostics for it. So the current treatment landscape that these people will face starts with stem cell transplant eligibility, which Anne was not eligible. She was not able to get that. If depending on that eligibility, it'll go into a mixed combination of proteasome inhibitors, immunomodulatory drugs, and monoclonal antibodies. From there, the people will be treated with advanced emerging therapies such as CAR T if you're if you've sure that's probably been heard before. BiTE therapy, bispecific T cell engagers, different immunomodulatory drugs, antibody drug conjugates are growing in popularity. But if you look at this, we're not going to go through this individually, but a lot of it is cell based. So whether it's bringing a T cell, a macrophage, an NK cell, or in the case of antibody drug conjugates, bringing in an external toxin. Um, so those are the therapies. But the reality, unfortunately, for multiple myeloma is that within a short period of time, over 85% of these patients will become relapse and they'll develop resistance to the therapies that are out there. And once they're in that condition, which we term RRMM for relapse refractory multiple myeloma, their outlook is less than 2 years for survival. So despite all of these wonderful advances, this disease is still incurable. So we've recognized that the need is obviously your next therapeutic needs to be safe and effective, but you need a different mechanism of action that can be cell independent if possible, and toxin independent. But does that even look like a drug at that point? Well, it can if you go back to our little trypanosome story with ApoL1 and your HDLs, which every single one of you have right now. So this is where we start. We think, okay, well, we know that it can bind a trypanosome, and we know we don't have a receptor for it. So can you then look at this bispecific antibody as the injected drug that binds ApoL1 in circulation and then travels to your cancer biomarker, gets taken up through a mechanism that we at least understand in the trypanosome, leading to cell death? So that's what we've tried. We've set out, we have made this antibody, and then we tried it in multiple myeloma first in the lab to see if there was any effect at all. And it started to work, at least in the mindset of binding and uptake. And they said they wanted to see some data. So let's look at some data. So this is flow cytometry. So you're taking live cells, that's real live images of the cells, and you're taking the antibody and you're adding in fluorescently labeled ApoL1 in the HDL, little complex. And what we're able to show is that this population of cells here actually has this is at physiological levels of the HDL as well. This is actually a 373% increase in binding and uptake of the cells compared to those that don't have the biomarker in question. So that was huge for us to see. And this is in a physiological relevant dose and time. So we're very encouraged at this point. But as some of you may know, just because you see high binding and uptake, it doesn't mean that you're going to have any correlation to killing because you can have high recycling rates. So we did the assay, right? We did the experiment. And that's actually what we were able to detect, is that with the addition of the bispecific antibody at physiological levels of the HDL, and this is in a 3-day experiment, which is really our gold standard of measuring something in the lab, we did see a near 40% increase in cell death. And that was the sign that we needed to say, okay, we do have the foundation of a therapeutic in this mechanism, which is effective against the multiple myeloma. It's not toxic in an off-target sense. As we saw, there was no binding. Well, there's also no off-target toxicity. There's no immune cell. We're not looking at NKs, T cell, macrophage, any of those other cells which can have their challenges. They also have their benefits, but they have a growing amount of challenges that they're trying to overcome right now. And there's no external toxins. So you got to think of an antibody drug conjugate essentially just has a monoclonal antibody and linked on is some sort of a drug. Well, one of the challenges that field has is if the linker releases at an inopportune time before it's met the target, you have a toxin just floating around. That's not an ideal situation. And they're building good controls around that and better science behind it. And that's a great field. We just know that you already have ApoL1 in you. You already have this pro-drug like in you already. So let's utilize it. And we also understand there is synergistic potential because it is a different mechanism of action. And we're starting to see that. I won't show that data today, but we are starting to see that in a few other indications. And we like to say it's an off-the-shelf approach because the regions that this antibody is specific for are native to everyone. It's native to a portion of APOL1 that's in everyone, and it's native to the cancer biomarker that's the same in everyone. So that was beautiful data, and we were excited about that. We felt like, okay, we're good. That's going to be our lead. We're going in that direction. But we did have the question of could we actually see an impact in other cancers as well? And we showed this data to some researchers at Emory, at the Winship Cancer Institute of Emory. And one of them jumped up and said, can we try this in pancreatic cancer? So sent the cell lines over, and that's exactly what we saw again. We saw 40% inhibition of growth in pancreatic tumors with a modified version of our antibody, which is basically means we just changed the biomarker that we were targeting. Still going to the same HDL. So this was the first time that we've seen that we can target both liquid and solid tumors with this approach. And we say we can target 10 of the malignancies. And what I mean by that is the targets that we're going after in the multiple myeloma and the pancreatic cancer are actually, those proteins are expressed in 22 different malignancies at different rates, but they all traffic the same way that we need it to for these two indications. So there is obviously a clinical and a commercial impact there. So that was huge. And that's the direction that we're going right now and where we're taking this company this year. So who are we? Well, you've seen me. I was the one that came along in 2010 and asked this crazy question about an intersection between a parasite and cancer. But Steve Haydick, Dr. Haydick had been working on this trypanosome for almost 50 years and has really pushed the boundaries on understanding what this particle can do and how it functions and how it works in the parasite. And it's really, I mean, it's published over 100 papers in the field. And Dr. Cipriano actually was in the lab in the late teens, 2017 to 2020, doing a postdoc working on several different projects, but joined us because he helped really solidify the concept of the bispecific antibody. So the three of us are the team that's really pushing this forward today. But I did mention Emory. We've added on several different members, both in the business side who've done concepts like this as far as taking therapeutic ideas out of the university environment and building companies around it. But really, it's also the team at Winship that has helped us move in the pancreatic space and understand what we have the ability to do, both there and as we see here with Dr. AJ Nuka on the multiple myeloma side, as far as running the clinical trials and understanding the impact that we can go in that direction. So a really great team, and we're growing now as we start to move towards IND preparations for the FDA. So yeah, this is where we've done it, and we've done this on such a small little pot of grants right now. It's really quite fascinating what we've been able to get done since going from 2021 with just the idea, really the first data after coming back in 2020, and again, the slowdowns with COVID that year, and getting 3 different grants from the Georgia Research Alliance, which is a great organization here in the state of Georgia. Winship and the University of Georgia Cancer Center coming together and funding us on the ideas of pancreatic, and then NIH and Georgia CTSA coming through as we've started to really build some complex animal models to test this, which those studies are underway now. So what we're aiming for is, yes, this is the year I'm like pitching this company, pitching Annate and going out and trying to raise money. And this is not a pitch to raise money. This is educating the great people at ARCS about what we've done and where we're going. And this is where we're aiming for. We're trying to go out and raise the money to do the optimization of the candidates, of the indications that we have, to do those really advanced mouse studies, the larger complex studies, and looking at IND studies, which are investigational new drugs, and further engagement with the FDA, and obviously looking for partnerships because we understand this will not be something we can do on our own. We're going to have companies joining up with us to get this further along. Um, so yeah, what have we looked at today? Well, we've looked at trypanosomes, this HDL that's in every single one of you, and how we can say, okay, well, if we zoom out, maybe we can look at that a different way. And oh, it's turned into a completely novel mechanism of action drug that's going with this novel delivery system that's really quite well proven. And oh, it can hit liquid and solid tumors, which is quite incredible when you're thinking about you're just repurposing an HDL. And for the legal side, Georgia does own the IP, and we have the exclusive licensing rights. So where are we going next? Well, we're pushing for raising money to develop further optimize this lead candidate here, and then looking at very advanced humanized mouse studies, some of which we're actually working on now with Winship, um, and then just getting prepared for the FDA. We know that's going to be a process. So learning every day, which is great. So I just want to say thank you so much for ARCS Atlanta. They have been nothing but absolutely wonderful, and I will never ever forget them for what they have done and continue to do to help us just share our story. And for the Hertz Global Foundation, we've had several meetings with the team in Hamburg and have had just really wonderful conversations with them about what they're doing over there and supporting their scientists and their students. And obviously the funding from GRA, CTSA, Emory, and University of Georgia Cancer Center. So with that, I will, oh, that's data. That's data if you want to see it, but we'll go from there. So I think, do you want me to just keep this? Are we good?
Yeah, I think we can take some questions now. We do have one so far, but just a reminder, everybody, if you have questions, directly related to the presentation or for Dr. DeJesus anyway, please put them in the Q&A function. It should be at the bottom of your Zoom screen, or you can drop them in the chat if you want. We're monitoring it. But we've got a few questions so far. So the first one is, people and I assume animals naturally produce different amounts of HDL. Does that matter in this treatment?
So that's a good insight. So yes, people do have differing levels of HDL. It's not as drastic as you would think. The numbers can seem drastic. In fact, we know that patients with multiple myeloma can have almost a 30% decrease in the overall HDL load. Um, but the question comes back to what are you measuring to get that HDL number? And Dr. Steve has measured, so how we would study the trypanosome and study this HDL particle would literally be having people come every single week and donate blood. We have a nurse come in, donate blood, and then I'd spend all week purifying it out. He's done that since the early 90s into late 80s, actually. So he's done it a very long time. It's thousands and thousands of people. And while the HDL level would change, the total population of HDLs that are actually APOL1 are less than 10%, and that number is very tightly regulated amongst everyone that we've seen. And every dose that we saw, every value that we came in and measured at, they all conferred they all were able to kill trypanosomes. Okay, no matter how much. So we knew, okay, well, even the smallest amount is still able to function as a defense molecule. And we've done our experiments on a range of doses, and we still see killing across a range. And we're still pushing that system to see, well, how far can you go? And we also know that there are drugs in the field that increase APOL1 particles. Interferon gamma is actually one of them. And if you have the unfortunate reality of dealing with anyone in cancer right now, that is one of the drugs that they will be given, depending on the malignancy. And that actually increases the amount of APOL1.
Sorry, I was muted. Is this potentially applicable to other blood cancers?
Yes. So the target that we're going after just on the multiple myeloma is actually present in five other blood cancers with the same trafficking patterns that we know we need. Um, and on multiple myeloma itself, there are four other targets that we have actively already routed out that we could use for killing just multiple myeloma. Um, we've done the scans to see, okay, we know we have to have a certain trafficking pattern, we have to have a certain expression pattern on the cell surface. And in liquid tumors, um, I think we stopped looking at 17 different liquid tumors that we could go after. And the solid tumors I think we stopped in the 20s. So that's not counting the 22 malignancies when I said of just the two lead indications we have. So there's a very large, essentially it's this. If it has a cell surface protein that's overexpressed like a lot of the cancer ones are, and it gets to the lysosome, that's it. That's all you need. Turns out there's hundreds, but we understand that the mechanism is simple, um, and we've had a lot of. In fact, we're looking even beyond cancer. Um, Autoimmune is one. We've looked at a few different pediatric diseases. I think the only disease that's actually come back to us from a clinician said, no, we probably don't want to go that route, is actually right now um, Alzheimer's, because they want to save whatever they can and repair those cells versus just kill them. You don't want to just kill the tissue that's there. You want to preserve it as much as you can. So, yeah, cancer you want dead. You want that gone.
Absolutely. We did have a question. How much of your funding currently comes from the federal government?
None.
None.
None of it is from the federal government. We're writing for those grants, those SBIRs, STTRs, R21s. We have an R01 that will be going in later in the fall with Winship. But right now, zero. So this is Georgia and private.
Wonderful. Someone said, what a great research story you've shared. What advice would you give to scholars about preparing for the business side of your research journey? And they wish you
Ooh,
success.
yeah. Um, the same grit and resiliency that you had to use and exercise and understand to get your doctorate is what you will need to do something like this. So I mean, I am climbing a wall that's pretty challenging because I didn't publish in cancer. I published in parasitology. My postdoc and my career didn't go into cancer. I chose careers to keep me close because this project could always come back, and it's a passion project. There wasn't much that kept me up at night in the sciences of excitement. This one does, still does to this day. It's been 15 years, and I don't sleep much, probably because I'm working quite a bit, but I just love, love this. And if you've got a question and you're fortunate enough to have funding to work on it, you will happily build that resilience and that determination to push into the business and find people to help you. We're pretty fortunate here with something called the Delta Innovation Hub at the University of Georgia that has put several people in our path to help us understand the business side of this. They've helped us on the patent side because I'm not a patent attorney. I'm not even going to pretend to be one. So that has been really, really critical. And just never, ever, ever be afraid to ask for help and just for clarification when you don't understand something. Because you will waste a lot of time trying to figure it out yourself, even with ChatGPT and AI. Just ask for help.
Right, exactly. Okay, I have a kind of a two-part question here.
Mhm.
So the first part is, have you analyzed APOL1 in the context of aging? Does it increase? And I'll let you answer that and I can go to the next half.
That's a good question. I don't know if we've looked in the space of aging. I'm trying to think of the mechanism of regulation and expression of how I understand it. I would say that just off the fact that I know that we've looked at the levels in multiple myeloma patients, which is a disease of older, I mean, it's a 55 plus disease. Um, and while those levels are overall HDLs are down, they're measuring a protein called ApoA1. They're not looking at ApoL1, and that's a good question. I will have to look into that. I don't know if there's a significant difference in age. That you got me. I don't know one. Be okay with saying I don't know.
Perfect. And then the second half, hopefully I won't butcher this, but have you considered optimizing your antibody to target multiple deleterious cell types, like exhausted T cells or senescent cells, in order to target more than cancer?
Yes. So one of the challenges of BITE therapy, which is a bispecific antibody targeting T cell, is two conditions called T cell exhaustion um, and oh my goodness, exhaustion, and I just went blank on the other one. I'm sorry, but there's two conditions that hit T cell. Oh, that's going to drive me nuts. So those are conditions that we've looked at because all it needs is a unique biomarker and a lysosome, and you can go after it. We have looked into that and what the mechanism would look like and specificity. That's the thing we'd have to be careful on. Um, so I can't say much on those directions of where we've gone, but we have started to look into those for both NK cell and T cell
Perfect. All right.
dysfunction, T cell dysfunction and
Dysfunction.
exhaustion. Haha, but
Perfect. I know that was going to drive you crazy. I have another one. Congrats on your discovery's progress. How does ApoLB relate to ApoL1?
so the ApoL family has several members that have differing roles of cell regulation. Okay, so ApoL1 and I know there's six ApoLs. A lot of them are functioning for regulation of apoptosis, autophagy, and just the regulation of the cell health. If the cell says, "Hey, I think we need to shut it down," and they'll start using those proteins to unlock other proteins that start a cascade of events that lead to cell death. ApoL1 is the only one that is secreted and is widely accepted as the whole purpose was just as a defense chemical against parasitology, trypanosomes. That's the whole thought behind why it's secreted, because there's no other reason that natively this pro-death like protein would ever need to be secreted. So that's most of them are just internal cell health checkpoints.
Interesting.
It's a good question. It's a very good question.
Yes, great question. Another one was someone with pancreatic cancer who has gone through chemotherapy with success and is heading for a surgery in July. Would they be considered eligible for one of your trials?
Ooh, I wish Dr. Zaidi was on the call. Um, I'm gonna say I'm not clear on what requirements for clinical trials, like what the check marks are that you have to hit to actually be eligible for that. I want that to be the case. We're unfortunately not quite there with the FDA to say yes for this year, unfortunately, but that is something that has gotten a lot of people very excited because it's a disease with not a lot of options, unfortunately.
Somebody asked, what would you predict would be the side effects of treatment?
That's a question that's come up lately because well, we asked, well, do we have any defense against APOL1 natively? So if it's so toxic, what are some thoughts on what it could do? Well, it's killing the cell and causing it. It's breaking the lysosome down, releasing those contents, leading to a myriad of cascade events that lead to cell death. So you're going to start releasing cell contents. So you could potentially see some activation of cytokine storm, but not to the same amount that if you're activating T cells like a BiTE or CAR T approach. So we'd imagine that there's probably going to be that to a small effect. Um, but we have yet to do the studies. We're actually doing those studies this year in vivo, at least in pancreatic, with the fully competent immune system to see what type of response do we see? Because it's always just been a question. The in vivo work that we've done in multiple myeloma, which has shown in vivo 40% function or reduction of tumor burden, those were in immune depleted background. So we can't say anything outside the fact that it's not toxic generally. We don't know anything about an immune response in that background right now. That's one of the goals that we're trying to do with raising money.
Perfect. What level of HDL do you determine as quote unquote high?
Um, right. So that's based off of APOL1 amount on micrograms per mil, and physiological is 3 to 10, and we're talking 50 to 100 micrograms per mil is very high. We it's expensive to do those experiments. It's definitely one you want to do once and be done with it because it's thousands and thousands of dollars of reagents to do them. Unfortunately, they show all we need. They said, "Yep, when you put a bunch on, cells die. Let's go back and see if we can add in an antibody to bring that what we call an EC50, that killing curve back to more physiological range." And that's fortunately what we've been able to do. So yeah, that's what we're talking about. 50 to 100 micrograms per mil of the protein is fortunately we're never going to make that.
Wonderful. I will be graduating with my PhD in molecular biology this year. Is there somewhere slash somehow I could contact you or find out more about your company and
Yes,
any potential open opportunities for research scientists?
yes. Um, just innatebitherapeutics.com is how you can get a hold of us. I'm on LinkedIn, just Eric DeJesus. And I just realized this slide is what normally had my emails on it, and they're not on there right now. But it's eric.dejesus@innatebitherapeutics.com. Uh, but yeah, if you just go to Innate, you'll be able to find us through there. Or LinkedIn. Yes, because I love, helping students out because I was there and I'm still there in a way of asking other biotech owners like, huh, what am I doing? How do I do this?
Yes, yeah, it's good to have that community for sure.
Absolutely.
I think this is our last question in case any come through in the next few minutes, but do you envision this as a first line treatment or one after exhaustion of other standard treatments?
We always want to be first. We always want to be the first therapy, first line of defense. But we understand that in the world of clinical trials, you're always going to start at the bottom end where you have the people who are triple, quad, and more refractory to various drugs that are out there. So if you're making a drug, and I'll say this with a little bit of a cavalier attitude, if you're making a drug and you don't want to be first in line, maybe reevaluate that. We absolutely think this has the potential because here's the thing: 100% of the people on this call, watching this on YouTube later, and anyone that you've ever known is protected against infection from an African trypanosome by this particle. speaking specifically to brucei for those later, 100%. No matter how much APOL1 you have, you're protected. So we've said, well, let's harness that power and say, why not towards cancer, towards an autoimmune disease, towards other malignancies of just general human disease? Why not? Why not have that power unleashed? It's just a matter of optimizing that delivery system, and that's what we're working very hard for.
Absolutely. We have another question that just came through.
Mhm.
Given the very dense stroma of pancreatic tumors, do you anticipate any challenges moving this treatment in vivo? How will you deal with those challenges?
That is a wonderful question. Whoever asked that, pat yourself on the back. Okay, it's like you just came from our lab meetings. Okay, so here's a really fascinating thing about pancreatic cancer. There's not many fascinating things in the treatment side, but on the scientific side, it's a very hypoxic tumor microenvironment in this disease. Very necrotic center, very challenging situation for bispecifics to come in with T cells. They just don't function that well. It's getting a little bit better, but overall, it's not been the greatest response. But the really fascinating thing is one of the proteins that's expressed, it's called H1F alpha, um, increases hypoxia. For brevity, it increases hypoxia, but just downstream of it is also ApoL1, and that just happens to get overexpressed as well. So pancreatic cancer overexpresses ApoL1. So there's a lot of it, and I mean like 15-fold higher. So you wonder, well, why is it necrotic center? Maybe it's a lot of ApoL1. We don't know. We have to test that. But getting the bispecific itself is actually not that challenging because they're highly vascular and it's just going through the bloodstream. So that's pretty easy to get there. The trick was, well, you just hope on enough of the HDL was there. Well, it's all secreted and they're apoproteins, which almost immediately form into HDL structures. So we're actually pretty encouraged that that is something that's going to be actually going our way in those studies. And we have Dr. Lisinski is the lead on those studies. So if you're interested, look up Dr. Greg Lisinski. Actually, let's go, if you don't mind, I'm going to go back and just leave the team up there because there he is on the bottom left. Um, uh, he was very excited when he saw this. I think we first met in 2022 and we've built a great little program testing this and looking in the different therapeutics potential of different pancreatic cancer, liver met, even melanoma with some other collaborators. So yeah, wonderful, wonderful research coming out of it. Great question. Very good question.
Absolutely. I think that is it. Of course, we have a few folks just saying that your research and
Yeah,
efforts are very encouraging and this is awesome work, and they're excited to see where you go.
yeah,
Um, well, I guess that wraps it up for us today. Thank you so much again for being with us. Let me put my little screen up just to have it there, and some more thank yous from the chat as well. But yes, thank you again, Dr. DeJesus, for walking us through your ARCS journey in research. We wish you the very best of luck on the path forward of your clinical development, and we really appreciate you taking some time out of your day to be here with us and share your work.
I
Um,
love it.
yeah, thank you. Thank you.
Thank you, ARCS, for everything you do. And one question I hope you take back to your members is how can we follow up with our alumni more and just get them more engaged? And I'm just really curious, is anyone out there still working on a project from many years ago? So just fascinating. I love it.
Yes, absolutely. Thank you again. And thank you to our audience members for attending today's program and sending such awesome questions. After the program, a recording and survey will be sent to you via email. So please be sure to pass along the recording link to any other members of your community and chapter who might be interested. We do look forward to hearing back from you via the survey as well. And we do use that feedback for future events. We do hope that you will join us for future ARCS Forward events. We'll have some really exciting ones coming up in the future. Thank you all, and I hope you all have a great evening and stay safe. Thank you.
Thanks. Take care, everyone. Appreciate it.